Hello, friends. It's a very unusual topic. I was asked to deliberate in Coimbatore on 27th April, ECG in toxicology. So I found it a bit challenging preparing this. So not a very conventional topic. So thank my colleague Dr. Mega who helped me develop this content. So the topic that was assigned to me was ECG in toxicology. So ECG changes rather in toxicology. So the way I thought I should cover these topics, the topics I would cover is a bit of a background as to what is the role of ECG in toxicology sort of a patients, whether it has a role in prognosticating or diagnosing, so on and so forth. And then we would look into the core physiological aspect that determine the changes in the ECG, which is cardiac action potential, and certain chemical movements that influence this cardiac action potential. Then we will talk about the established algorithms that are present in the literature, which are mainly divided into three categories. So the ECG changes with sinus rhythm, and the changes that happen with bradycardia, and the changes that happen with tachycardia. So they have categorized the toxicities amongst these three algorithms. But let me caution all my audience that there is a lot of overlap between a lot of drugs that cause ECG changes. So there is a huge overlap. And then we'll move into specific drugs which are commonly seen in SA because we really don't want to speak on very unusual drugs. The commonest sort of a culprit is usually tricyclic antidepressants. I just put three cycles as the chemical structure. And we look into potassium channel blockers and sodium channel blockers. So most of the categorization of the drugs that causes ECG changes come in this potassium channel blockers and sodium channel blockers. And we'll talk about calcium channel blockers, digoxin, which is very commonly sort of used and seen as well. And we'll look into some drug of abuse like cocaine. Okay, so these are the categorizations with regards to specific drugs. Then we'll talk about how do we predict prognosis. I think the take-home message for all my audience is just focus on this one last slide that I'll talk. How do we predict and how do we algorithmically look into these ECG changes from the prognostic standpoint and summary. So this is how I would cover this topic. So when you look at the background, so all of us know that any toxicology come, we have to do ECG, and ECG is terribly important to look for any early changes which may predict some arrhythmias in these patients. And many of the cardiotoxic drugs have an effect on this myocardium and have effect on this conduction system, which lead to some of the deleterious changes. And the main drugs which have seem to have cardiotoxic effects are mainly the sodium and potassium channel blockers or certain adrenergic drugs which causes vasodilation or vasoconstriction. And there are certain drugs which act by altering the metabolic activity, which leads to dysfunction of the myocardium. So these are some of the basic sort of drugs that tend to have certain effects on the myocardium. And when we dwell into core physiological standpoint, we need to understand that the chemical changes that tend to facilitate this action potential of the myocardium. So as you read this in physiology classes in MBBS, so that cardiac action potential has, of course, you have four phases, which is depolarization phase, end of depolarization, and rapid repolarization, and you have a resting potential. So these are the four changes that tend to happen. So during depolarization, you have learned in your physiology there is increase in the cellular sodium, and then you have the end of the depolarization where the sodium channel close. Then it reaches a plateau phase, which is called phase 2, where there is increase in the calcium and depletion of potassium. There are these chemical changes that happen during the action potential of any cell, of the cardiac cell. And during rapid repolarization, potassium tends to come down and there is a closing of the calcium channels. And phase 4 is where there is leakage of potassium that tends to happen. So these are typically the stages of cardiac action potential where there are certain chemical changes. Why this is important is any drugs that are acting on blocking the sodium where it is needed to cause depolarization, any drugs that are causing blocking of potassium where there is meant to be rapid repolarization that is meant to happen. If potassium channels are blocked, there is increase in the potassium, it causes rate repolarization and deleterious effects. So these are the chemical changes which have a deleterious effect on your cardiac activity and the ECG. And if you have to look at the correlation of this cardiac action potential to the ECG trace, as you see, phase 0 and phase 1 sort of corroborates with the QRS complex, and phase 2 and phase 3 corroborates with the HT and the T wave. So this is in rough essence how cardiac action potential corroborates with the ECG waveforms. So when we look at the normal ECG or the ECG in toxicology, it helps us in screening of the patients, try to identify and pick up the patients who are more vulnerable for cardiac toxicity and deleterious effect of any of the toxin that the patient may have taken. And it may sometimes help in diagnosis of the underlying problem. Because of course, if you have a patient with prolonged QTC, you would have to think of drugs that causes prolonged QTC. So may help in diagnosis and most importantly, even prognosis, like in tricyclic overdose. So the widened QRS helps us in prognosticating the patients who are at a risk of developing tachyarrhythmias. So ECG does give you some insights into establishing diagnosis, screening the patients, help in prognosticating, and even guide the management. And what are the distinct advantages of ECG? It is non-invasive, and we know that there is not much cost to it. It is easily available, and it helps in understanding the electrical conductivity of the heart or automaticity of the heart. So basically, one look at the ECG, you know whether there is any problems in the conduction system in the heart. So these are some of the distinct advantages of ECG. And what do we look into ECG? Again, going back to our MBBS physiology days, or even at the physician days, we have to look at the rate, we have to look at the rhythm, then we have to look at the PR interval, then we have to look at the QRS interval, then we have to look at the QT interval, because all the changes that get reflected from the toxicity, thus some disturbance in the PR interval can cause varying AV blocks, which means your PR intervals can be prolonged, or you can have a drop QRS or QT. QT prolongation is something that will be very repetitive in my presentation because most of the cardiac toxic drugs that I'll be speaking tends to cause a QT prolongation, which is deleterious. And of course, QRS, we looked into the QRS also, the width of the QRS, the duration of QRS. So when we talk about the sodium channel, I think if you remember this ECG, one take home is always when there is a toxicity patient, one thing you need to see is whether there is an R wave in the AVR and whether there is a S wave in 1 and AVL. So I'm sure many of my intensive care practitioners who have trained with me, they know when I'm doing rounds, we always look for whether there is a S in 1 and AVL and whether there is a right axis that is evolving. So look for R wave. So if there is an R wave in AVR in the clinical context of some toxicity, you have to think there may be some sodium channel blockade that may be happening. And most importantly, you look at QT interval wherever there is a suspicion of toxicity, because any prolonged QT may be an early indicator that there may be some sort of a toxicity, cardiac toxicity drug that may have deleterious effect, because prolonged QT ultimately, as you see, gets prolonged and leads to toxicity pointis and ventricular, polymorphic ventricular tachycardia. So this is the deleterious aspect of any poisoning. And many of the sodium channel blockades or tricyclic antidepressants, which also come under the sodium channel blockades, they cause prolonged QT and that can lead to toxicity pointis and can cause ventricular tachycardia. This is what we are terribly worried. So in ECG, in toxicity, look for R in AVR, look for S in 1 and AVL, and you look for QT, because if these are abnormal, then there may be a problem with your sodium channel blockade or tricyclic antidepressants, which have to be kept in mind and monitored. So let's into what are the established algorithms that has been referenced in the literature. So as I said, the algorithms are with normal sinus rhythm or with bradycardia or with tachycardia. So we'll first look into normal sinus rhythm. With normal sinus rhythm, the key thing that you would see is some sort of a blocks. So this is first degree AV blocks where, as you see, there is a prolonged PR interval. Then there is this second degree or the second degree AV block type 1, which is called Wenckebach's. As you see, there is a progressive prolongation of the PR interval, and then there is a dropped QRS. So obviously, this is a Wenckebach's phenomenon. And then you will have a second degree AV block, which is Mobitz 2, where PR intervals remain same. And then there is a dropped QRS, which happens due to beta blockers and calcium channel blockers. So these are the typical types of blocks that tend to happen with toxicity due to beta blockers or calcium channel blockers. And this happens with a normal sinus rhythm. So have that in mind very clearly. And as already mentioned, in ECG, always look for R in AVR, S in 1 and AVL. If you see this pattern, it does denote that there is some cardiac toxicity that is happening. Obviously, if you are suspecting, so it could be sodium channel blockers and tricyclic antidepressants. So one needs to know what are all the sodium channel blockers that tend to cause. So the take home at the end of this is look for R in AVR, S in 1 AVR, look for QTC. Sodium channel blockers, you have a great list of drugs. So the class 1 antiarrhythmics. I have not put certain drugs that we don't use at all. And many of these drugs we have only learned from MBBS, but we have never used this. But we have to remember some of them. At least I put only the ones which you can easily remember: quinidine, procainamide, and you have class 2C drugs also, which can also come as a sodium channel blocker, flecainide and encanide, and local anesthetics, which we tend to call. Because there are other drugs, I'm only putting the ones which we tend to use. Bupivacaine and ropivacaine can cause sodium channel blockade, and this can cause cardiac toxicity. I'm sure many of you know when you give a high dose of local anesthetic of this nature, it leads to arrhythmias and cardiac arrest. So be aware, bupivacaine and ropivacaine causes sodium channel blockade. Look for R wave in AVR, and that is an indication that there is some cardiac toxicity that is happening. And phenothiazine. See, all antidepressants, all antipsychotics, they come into this sodium channel and potassium channel sort of a blockers. So all phenothiazines like thioridazone and all the antipsychotics, they have ability to cause arrhythmias by causing sodium channel blockade. And antimalarials, chloroquine, quinidine. So I only put drugs which we tend to use clinically. Although these antiarrhythmic drugs, some of them we don't use very commonly, but at least some of them which we have at least heard of and tried to use, I have mentioned. So these are the drugs to be borne in mind, which can cause cardiac toxicity. So that is about, so they all have normal sinus rhythm, but you have to look at the early indicators, which is R in AVR and S in 1 and AVL is something that you need to look at. So normal sinus rhythm, someone is very obtunded. Can it cause ECG changes? Yes, because opioids can cause. So opioids, although we use so much in ICU, bear in mind, they can cause prolonged QTC. So opioids is something you need to bear in mind. And you need to bear in mind normal sinus rhythm, someone very obtunded, look for QTC if you're suspecting opioids. And obtundation can happen due to antidepressants and antipsychotics. As I said, they can tend to cause sodium channel blockade and they cause prolonged QTC. So anyone who is having, and many patients now are on antidepressants or antipsychotics, always look at QT interval, always look for R in AVR, and you need to look for QRS. These are the three things that you need to look at to determine if patient is at a risk for arrhythmias, because it can be life-threatening. And of course, these do not cause obtundation, but this cause prolonged QTC. These antibiotics, erythromycin, quinolone. So in ICU, most of you, at least my trainees, know that we have a high threshold to use quinolones because quinolones are known to cause QTC prolongation. And we try to de-emphasize over usage of quinolones in ICU. Cotrimoxazole, which we tend to use in sort of PCP infections, can cause QT prolongation. And azoles, azithromycins, that we, or azoles, the antifungals, sorry, we use, that can also cause QTC. So this is the categorization of drugs: antibiotics, antifungals, antidepressants. So easy to remember. So it is macrolides, antifungals, antidepressants, antipsychotics are the ones which causes prolonged QTC, which are commonly used in ICU along with opioids. So what about this, friends? So if someone has with this normal toxic bradycardia, they have bradycardia and then they have nystagmus of this nature, then there is something that needs to come in mind. It's a lithium toxicity. So if someone has nystagmus along with sinus bradycardia, so look at possible lithium, because lithium is used as for a mood stabilizer and for MDP, maniac depressive psychosis. So they do use lithium. So it comes in that category, and they can have nystagmus of this. There is only one drug which is asked as an MCQ which causes vertical nystagmus. So if you look at it, this was used in anesthesia before. Now people are using it as a drug of abuse, which is pencyclidine. So this causes vertical nystagmus like this, and this is used as an angel dust. It causes dissociative amnesia, and this is a drug of abuse now. So you may have young teenager coming with pencyclidine toxicity. They consume it as an angel dust as a rave parties. It can cause vertical nystagmus like this, and they can have bradycardia. They won't have tachycardia. Bradycardia with a vertical nystagmus, it's pencyclidine. Lithium toxicity, it's a horizontal nystagmus. And bradycardia, I said sinus rhythm can come with AV blocks. 1, 2, and 3. Even with bradycardia, they can have type 1 block, Wenckebach's type 2, and Mobit's type 2 blocks, and even complete heart block, they can come with bradycardia. So this is the categorization of toxins coming with this. And as I already said, beta blockers, calcium, they cause bradycardia with these blocks, and digoxin. Digoxin causes this block. So this is the categorization or algorithmic approach to bradycardia causing sort of these blocks due to this drug toxicity. So what are the other drugs? Opioids, as I said, don't undermine the role of opioids. We use a lot in ICU. It can cause QT prolongation. And in ICU, the type of poisons that we see is OP compound. So OP compounds do come with bradycardia. So if someone comes with bradycardia with a pesticide smell, obviously, you know, the cause for bradycardia is the OP compound poisoning, and you have to use obviously atropine as an antidote for this. And so look at this waveform. So what does this waveform say? Again, as I said, you see an R in ABR, and you are seeing sort of an RBB pattern. You see a S in one, and then is a huge R wave. So if you see a pattern like this with R in ABR and RBB sort of a pattern, so they are also caused by tricyclic antidepressants and class 1A and class 1C antiarrhythmics. Just remember quinidine, procainamide, enconide, and flecainide. They are the ones which typically causes this sort of a pattern with a sodium channel blockade and leading to RBBB sort of a pattern. And what about Brugada syndrome? So if someone, Brugada is not caused by any poison, but if they have an underlying genetic predisposition to the Brugada, they can be precipitated by tricyclic antidepressants or by this sodium channel blockade. So this you have to understand. So for all my trainees, type 1 Brugada is you have to only look at V1. In V1, you have an ST elevation with a deep sort of a depression. This is type 1. Type 2, we call it as a saddle pattern because this looks like a saddle. There is an elevation, depression, and then there is a second elevation. We call it as a saddle pattern. This is type 2 Brugada. So if someone has a genetic predisposition, Brugada typically presents with RBB sort of a situation with a deep T inversions or ST elevation in V1. And if you see this pattern, it can be precipitated by this tricyclic antidepressants and class 1A and 1C antiarrhythmic drugs. So we spoke about normal sinus rhythm and the drugs which manifest with sort of toxicity with normal sinus rhythm. Drug toxicity or toxicology causing bradycardia, we saw toxicologic bradycardia. We looked into tachycardia. What are the toxins that presence with tachycardic manifestations? So if someone has tachycardia with a wide QRS, so as I said, in toxicology, you only look at R in ABR, you look at maybe R in V1, and you look at S in 1, and you have to look at QRS, and you have to look at QTs. If you cover these elements, you would have at least tried to look into the key aspects that you would see in the toxicity. So all QRS problems are due to antidepressants and antipsychotics. So antidepressants, any antidepressants, if they have overdosed, it can cause wide QRS. So venlafaxine, bupropion, mirtazapine are commonly used. Antipsychotics, the commonest ones we use in ICU is haloperidol. Sometimes we use carbamazepine as a mood stabilizer or phenothiazines. So these can cause wide QRS. And again, in all this toxicity, only class 1A and 1C antiarrhythmics tend to recur. Quinidine, procainamide, flecainide, and enconide. Antihistamines, which we tend to use often, that can also cause wide QRS, diphenhydramine. So anyone who has overdosed with all antihistamines, first thing you have to see is look at QRS, if there is a widening of the QRS. And I'll talk about how much wide is more significant. More than 2.5 squares is very significant. And they can come with narrow QRS. Narrow QRS typically happens when there is an adrenaline or sympathomimetic drugs, typically adrenaline, or anticholinergics like antidepressants, antipsychotics, antihistamines. They also can come with narrow QRS, sort of a tachycardia, or cocaine, sort of a toxicity. So these are the ones which causes tachycardia and narrow QRS. So narrow QRS or wide QRS, it's a diabolical. Antihistamines can cause broad QRS, it can cause narrow, and antidepressants can cause broad QRS, it can. So they're all diabolical drugs. At different dosages, they behave differently in different individuals. So that is, don't get confused. They can cause wide QRS, they can cause narrow also. So they can act both extremes. So these are the beauty of all these toxic drugs. So let's dwell into specific drugs. So we spoke about algorithmic approach with sinus rhythm. bradycardia, and tachycardia. Let's look into specific drug toxicity. So TCA. See, just look at this ECG, friends. I've been uh, reiterating or repeating like a parrot R in ABR. So you look at R in ABR, S in 1, S in ABL. There is a problem here. There is a problem with toxicity. It's a TCA toxicity, tricyclic antidepressants. When do we say there is a QRS is broad? So if QRS is more than 100 milliseconds, which is more than 2.5 small squares, it means the tricyclic antidepressant is creating a problem, and the risk for the patient is they can have seizure. If QRS is more than 160 milliseconds, which is more than 4 small squares, then it means they can lead to arrhythmias. It can be toxicity points or ventricular tachycardia, polymorphic VT can happen. So this is very, very important because we do get many patients in ICU with TCA overdose. We always look into the squares. If it is more than 2.5, they tend to have seizures. That's why we give bicarbonate, we alkalinize them, and we keep monitoring the QRS. If it's more than 4 small squares, then they are at a risk for arrhythmias. And we do see patients coming with arrhythmias. And the third pattern is you will have right axis. See here, this patient has a right axis deviation, and there is R in ABR, and R and S ratio will be more than 0.7. These are the typical characteristic features of tricyclic antidepressant. What about potassium efflux? So don't get too much bewildered or overwhelmed with sodium efflux and potassium efflux. The drugs are little similar. You don't have to memorize this drug. But as I showed you the cardiac potential, cardiac action potential, potassium is needed for repolarization. So if you have a potassium channel blockade, then your cellular potassium tends to increase, and this repolarization, the late repolarization tends to get delayed, QT gets prolonged, and then they go into toxicity points. So that's why any potassium channel blocker delays the repolarization, prolongs the QT, pushes them into VT. So that is something. So what are the key potassium channel blockers? Very similar to sodium channel. You don't have to memorize. It is class A, class 1C, but the one addition, in addition to sodium channel, another toxin is amiodarone and sotalol or potassium channel blockers. And as I said, antidepressants, antipsychotics, antihistamines, they are the common culprits. All of them can cause broad QRS, and most of these come under sodium channel and potassium channel blocker. And the ones we use commonly in ICU is haloperidol and chlorpromazine. Antimalarials, they can cause this problem. We know when a patient is on quinine, we know we have to monitor QTC because that is something that gets prolonged and puts them at a risk for arrhythmias, and macrolides, azithromycin. So these are the typical potassium channel blockers, and we use this. I've only put drugs which we use in ICU because I don't want to talk theory and talk about other drugs which we don't not heard or not use commonly. So all the drugs we use in ICU, amiodarone we use, esmolol, sotalol, metoprolol we use. So sotalol is known to more cause. And antidepressants, antipsychotics, most commonly we use haloperidol. So that's why we have to bear in mind, if you are using haloperidol, high doses, please keep an eye at least having an R in B1 or ABR and look at the QRS because this can lead to arrhythmias. And what about cardiac? Because many of our patients, if they have heart failure, they would be on digoxin. So if they're on digoxin, typically you have, this is an MCQ question, Salvador Dali sagging sign. So this is a typical sign that is asked in MCQs. So they have this sort of a pattern, which we call it as Salvador Dali sagging sign. So what are the key aspects in digoxin? This is not digoxin poisoning. Any patient who is on digoxin, if you do an ECG, if digoxin is in a therapeutic range, you would see these changes in the ECG, which is not toxicity. Toxicity leads to other problems. So someone who is on digoxin, PR interval gets prolonged, more than 240 milliseconds. Actually, QT gets shortened. This is the only drug where QT gets shortened, and there is a late peaking of the T waves in digoxin poisoning. And of course, you'll have that sagging of the ST segment, which we call it as Salvador Dali sagging sign, and you have prominence. So these are the typical features you may see in a patient who is on digoxin and where digoxin level may be in therapeutic range. If they go towards toxicity, then these things happen. So when digoxin toxicity happens, then you'll have atrial tachycardia with high degree AV block. Then you can have ventricular escape beat. Then you have mainly PVCs, premature ventricular contractions. The key thing that we see in ICU when someone comes with digoxin is ventricular bigeminy or trigeminy or atrial tachycardia. So this is ventricular bigeminy. As you see, you have a ventricular beats alternating in couplets. So we call it as ventricular bigeminy. And then if you don't treat it, and you don't notice this, they will go into polymorphic leak. So these are some of the key. These are the changes you'll see in toxicity. Normal ECG changes, you'll see prolonged PR, shortened QT, late peaking of the T wave, and Salvador Dali sagging sign is what we see. And nerium oleander, because we do have patients who come with consumption of yellow oleander. In India, in South India, we see more of yellow oleander. Nerium oleander is what is more referenced. All parts of this plant contain cardiac glycoside. The flowers contain, the stem contain, leaves contain, roots. So if patient consumes any part of this plant, they can come with digoxin toxicity. And the toxic active component of this is oleandrin and nerium. What about calcium channel blockers? So we do get very often patients with calcium channel blocker toxicity. The calcium channel blockers causes conduction disturbance at the various sort of the SA node, at the AV node, and it causes bradycardia and it causes escape rhythm. And the beauty of CCB is based on the severity of CCB toxicity, the manifestation ECG can vary from first degree AV block. Then if more calcium channels, it will go to junctional rhythm. If it is even more, it will go into fascicular block and they'll go into complete heart block. So all these commensurates to the amount of calcium channel blockers patients have taken. Very recently, we've had one calcium channel blocker which came with complete heart block. We had to put the patient on ECMO with a proper cardiogenic shock. So on and so forth. So calcium channel blockers, they are rate slowing and they affect the conduction system in the heart. What about cocaine and amphetamine toxicity? Even cocaine and amphetamines, all these are sodium channel blockades. What are we seeing? We are seeing R in the AVR, and then sometimes we do see ST elevation, and then we see the tachycardia pattern. So this typically happens in cocaine and amphetamine toxicity, which are very similar to the sodium channel blockade. So you see deep S in one, and you see S in AVR, you see R in AVR. So typically tell you there is a sodium channel blockade that is happening, which is leading to this sort of a disturbance due to the underlying toxicity. I think you can forget all I have spoken. If you only remember this flowchart, I think you would be able to effectively prognosticate the patients who come to ICU only seeing the ECG. Just remember this slide at the end of it. Prediction of ECG, hospitalization prognosis using ECG. How do you predict which patients are at the risk of? Just remember this. You can forget all that I have said. Just remember this. This is a very beautiful algorithm. If you are suspecting some drug toxicity, two things you have to look, whether ECG has ectopy or ECG is not having any ectopy. Just look if it's a normal ECG or if there is ectopy. If there is ectopy, means it's already manifesting with arrhythmias, patient is at a very high risk of having arrhythmias. There is 64% of risk of acute cardiovascular event. It means they can have arrhythmia. So if you have a patient with toxicity who is already showing PVCs, who is already showing prolonged QTCS, some ectopy, it means there is going to be an arrhythmia. You have to treat them immediately. If there is no ectopy, then you have to look at two things, whether they are in sinus rhythm or there is no sinus rhythm. If patient is in sinus rhythm, first thing you look is QTC. Whether they are in normal QTC, it means very low risk. And the risk of cardiovascular events in toxicity is reported. Or you look at long QTC, then the moderate risk, 26% cardiovascular events. Or if it is QTC is more than 500 milliseconds, it means they are at a very high risk, more than 38% of acute cardiovascular. And so if you remember this, you will be very easily able to categorize whether your patient is at a risk of cardiac toxicity due to the drug. So QTC. So I would add on to this, although this is referenced in the literature, you look at QTC, look at QRC, look at R in V1. If you look at these three, you will be able to pretty much ascertain whether there is some toxicity happening. So summary of this presentation, use systematic approach with your ECG to determine the patients who are at a risk of ECG changes, and look at normal sinus rhythm or bradycardia. They can present with any of these blocks, and if they present with first degree, second degree, third degree, so main problems would be possibly beta blockers, calcium channels, or to some extent digoxin. If you have a prolonged QT, which can happen due to multiple drugs, including opioids, so bear in mind that this can lead to torsades de pontis, and you have to pay attention. And digoxin is something you will see this typical Salvador Dali sagging sign and all the changes that I mentioned. And sodium channel blockade, look at the R wave in AVR, look at S in 1. If this is seeing, then it will indicate you either there is a sodium channel blockade and you may have to take necessary action. So this is just the summary. of what all I have spoken. So thank you, friends. So request you all to submit valuable work to Journal of Acute Care. Of course, you can visit my website to rehear to this lecture. Thank you. Thank you, one and all.